Welcome to this educational video about contrast-induced nephropathy, also known as CN. This condition refers to kidney damage that occurs after exposure to contrast media, often used during medical imaging procedures. Understanding CN, its causes, effects, and prevention is crucial for anyone working in or interacting with the medical field. So what causes contrast-induced nephropathy? The primary culprit is the intravenous administration of odonated contrast media, commonly used in procedures like CT scans, angiograms, and cardiac catheterizations. Certain patient factors significantly increase the risk, including pre-existing kidney disease, diabetes, dehydration, heart failure, advanced age, and the use of nephrotoxic medications. The dose of contrast also plays a role. Higher doses generally correlate with a greater risk of CN. Let's delve into the pathophysiology, or how CN develops. Several mechanisms are believed to be at play. Firstly, contrast media can cause direct toxic effects on the kidney cells, particularly in the renal tubules. Secondly, contrast media can lead to renal vasoconstriction, reducing blood flow to the kidneys and causing ischemia. Thirdly, contrast media can increase the production of reactive oxygen species, leading to oxidative stress and cellular damage. Finally, contrast media can increase the viscosity of the tubular fluid, leading to tubular obstruction. All of these factors contribute to a decline in kidney function. Epidemiologically, contrast-induced nephropathy is a significant concern. It is estimated to occur in 2 to 7% of patients receiving contrast media. However, this incidence can be significantly higher in patients with pre-existing risk factors, reaching up to 30% in individuals with pre-existing chronic kidney disease or diabetes. CN is a major cause of hospital-acquired kidney injury and can lead to increased morbidity, mortality, and healthcare costs. Often, contrast-induced nephropathy is asymptomatic, especially in its early stages. However, detectable signs and symptoms include a rise in serum creatinine levels, typically within 24 to 72 hours after contrast administration, and peaking within 3 to 5 days. Other potential symptoms include decreased urine output, fluid retention, swelling in the legs, ankles, or feet, fatigue, and, in severe cases, symptoms of kidney failure such as nausea, vomiting, confusion, and shortness of breath. Diagnosing contrast-induced nephropathy relies primarily on laboratory tests. The key diagnostic criterion is an increase in serum creatinine levels of 0.5 mg/dL or more, or a 25% or greater increase from baseline within 3 days of contrast exposure. Other tests, such as urine analysis and kidney function tests, can help to assess the severity of kidney injury and rule out other potential causes. Importantly, it is crucial to establish a baseline creatinine level before contrast administration, especially in high-risk patients. While there aren't distinct types of CN in the same way as some other diseases, we can classify it based on severity. The severity can be graded by the degree of increase in serum creatinine. Mild CN represents a small increase. Moderate CN indicates a more significant increase but typically resolves without long-term consequences, and severe CN involves a substantial increase, potentially requiring dialysis and leading to chronic kidney disease. The primary focus of treatment and management for contrast-induced nephropathy is supportive care. This includes ensuring adequate hydration, avoiding nephrotoxic medications, and monitoring kidney function closely. In severe cases, dialysis may be necessary to remove waste products from the blood and support kidney function until the kidneys recover. There is no specific medication to reverse the damage caused by contrast media. Treatment focuses on minimizing further injury and supporting kidney function. Prevention is key in managing contrast-induced nephropathy. The most important preventative measure is adequate hydration, both before and after contrast administration. Intravenous normal saline is often administered to increase kidney blood flow and flush out the contrast media. Identifying and addressing pre-existing risk factors, such as kidney disease, diabetes, and heart failure is crucial. Minimizing the dose of contrast media and using low-osmolar or iso-osmolar contrast agents can also reduce the risk. Some studies have explored the use of medications like N-acetylcysteines in AC, but the evidence for its effectiveness remains inconclusive and is often reserved for high-risk patients. The prognosis for contrast-induced nephropathy varies depending on the severity of the condition and the patient's overall health. In most cases, kidney function recovers within a week or two. However, in some patients, CN can lead to chronic kidney disease or even end-stage renal disease requiring long-term dialysis. Recent research is focused on developing more sensitive biomarkers for early detection of kidney injury and identifying novel therapeutic targets to prevent or mitigate CN. Ongoing studies are also exploring the potential role of newer contrast agents with lower nephrotoxic potential. Staying informed about these advances is critical for providing optimal patient care.